dear students. Welcome to the video lecture series on general methods for the treatment of poisoning for the syllabus set by Swami Ramanand Tirth Marathwada University for students undergoing Bachelor of Pharmacy course 8th semester belonging to the subject clinical pharmacy and drug interaction. The subject code is BPH 87. Myself, Dr. J P Lavande, Associate Professor, Department of Pharmaceutics, Shivlingeshwar College of Pharmacy, Almala, Taluka Ausa, District, Latur. In this, already we had covered all the details associated with introduction, signs and symptoms, diagnosis, testing in our previous video lectures. Now this lecture that deals with the different methods of treatment and prevention for the poisoning. The treatment includes supportive care, activated charcoal that is to be used for serious oral poisoning cases, and sometimes the specific antidotes that are used including dialysis, and only in rare cases the gastric emptying or what is said to be the gastric lavage that is to be carried out. Seriously poisoned patients may require assisted ventilation or treatment of cardiovascular collapse. Patients with impaired consciousness may require continuous monitoring or restraints. The discussion of treatment for specific poisoning is general and does not include specific complexities and details. Consultation with a poison control center is recommended for any poisonings except the mildest to most routine. The initial stabilization is required by maintaining the airway breathing and circulation, the intravenous supply of naloxone, intravenous admixture of dextrose and thiamine, the fluids that are to be given by intravascular route, and sometimes the vasopressors agents. The airway breathing and circulation must be maintained in patients suspected of a systemic poisoning. Patients without a pulse or blood pressure require emergency cardiopulmonary resuscitation, that is said to be the mouth-to-mouth resuscitation. If patients have apnea, that is difficulty in breathing or compromised airway, for example foreign material in the oropharynx or decreased gag reflex, an endotracheal tube that should be inserted. If patients have respiratory depression or hypoxia, supplemental oxygen or mechanical ventilation that should be provided as it is needed. Intravenous naloxone that is to be given in 2 mg in adults, 0.1 mg per kg in children. Doses as high as 10 mg may be necessary in some cases that are given. It should be tried in patients with apnea and severe respiratory depression while maintaining airway support. In opioid addicts, naloxone may precipitate withdrawal, but withdrawal is preferable to severe respiratory depression. If respiratory depression persists despite use of naloxone, endotracheal intubation and continuous mechanical ventilation are required. If naloxone relieves respiratory depression, patients are monitored. If respiratory depression recurs, patients should be treated with another bolus of intravenous naloxone or endotracheal intubation and mechanical ventilation. Using a low dose continuous naloxone infusion to maintain withdrawal, to maintain respiratory drive without precipitating withdrawal has been suggested, but in reality can be very difficult to accomplish. Intravenous dextrose, the 50 ml of 50% solution for adults is advised. 2 to 4 ml per kg of a 25% solution is advised for children. Intravenous dextrose should be given to patients with altered consciousness or CNS depression unless hypoglycemia has been ruled out by immediate bedside determination of blood glucose. The 100 milligram intravenous thiamine has to be given. Thiamine is given with or without glucose to adults with suspected thiamine deficiency, for example, alcoholics, undernourished patients. Intravenous fluids are given for hypotension. If fluids are ineffective, invasive hemodynamic monitoring may be necessary to guide fluid and vasopressor therapy. The first choice vasopressor for most poison-induced hypotension is norepinephrine 0.5 to 1 milligram per minute intravenous infusion, but treatment should not be delayed if another vasopressor is more immediately available. Topical decontamination is most important. Any body surface including the eyes exposed to a toxin is flushed with large amounts of water or saline. Contaminated clothing including shoes and socks and jewelry should be removed. Topical patches and transdermal delivery systems are removed. Activated charcoal is used. Charcoal is usually given particularly when multiple of unknown substances have been ingested. Use of charcoal adds little risk unless patients are at a risk of vomiting and aspiration, but has not been proved to reduce overall morbidity or mortality. When used, charcoal is given as soon as possible. Activated charcoal absorbs most toxins because of its molecular configuration and large surface area. Multiple doses of activated charcoal may be effective for substances that undergo enterohepatic recirculation, for example, phenobarbital, theophylline, and for sustained release preparations. Charcoal may be given at 4 to 6 hour interval for serious poisoning with such substances unless bowel sounds are hypoactive. Charcoal is ineffective for caustics, alcohols and simple irons, for example cyanide, iron, other metals, lithium, etc. The recommended dose is 5 to 10 milligram that of the suspected toxin ingested. However, because the amount of toxin ingested is usually unknown, the usual dose is 1 to 2 gram per kg, which is about 10 to 25 gram for children less than that of the 5 years and 50 to 100 gram for older children and adults. Charcoal is given as a slurry in water or soft drinks. It may be unpalatable and results in vomiting in 30% of the patients. Administration via a gastric tube may be considered, but caution should be used to prevent trauma caused by tube insertion or aspiration of charcoal. Potential benefits must outweigh the risk. Activated charcoal should be probably used without sorbitol or other cathartics, which have no clear benefit and can cause dehydration and electrolyte abnormalities. Gastric emptying. Gastric emptying, which used to be well accepted and seems intuitively beneficial, should not be routinely done. It does not clearly reduce overall morbidity or mortality and high risks. Gastric emptying is considered if it can be done within 1 hour of a life-threatening ingestion. However, many poisonings manifest too late, and whether a poisoning is life-threatening is not always clear. Thus, gastric emptying is seldom indicated, and if a caustic substance has been ingested, is contraindicated. If gastric emptying is used, gastric lavage is the preferred method. Gastric lavage may cause complications such as epistaxis, aspiration, or rarely oropharyngeal or esophageal injury. Syrup of ipecac has unpredictable effects, often causes prolonged vomiting and may not remove substantial amounts of poison from the stomach. Syrup of ipecac may be warranted if the ingested agent is highly toxic and transport time to the emergency department is usually long, but this is uncommon. in the countries like US. For gastric lavage, tap water is instilled and withdrawn from the stomach via a tube. The largest tube possible, usually more than 36 French of adults and 24 French for children. French, that is the unit which is used for measuring the length, is used so that tablet fragments can be retrieved. If patients have altered consciousness or a weak gag reflex, endotracheal intubation should be done before lavage to prevent aspiration. Patients are placed in a left lateral decubitus position to prevent aspiration and the tube is inserted orally. Because lavage sometimes forces substances further into the GI tract, stomach contents should be aspirated and a 25-gram dose of charcoal should be instilled through the tube immediately after insertion. Then early cut, about 3 ml per kg of tap water are instilled and the gastric contents are withdrawn by gravity or syringe. Gastric lavage continues until the withdrawn fluids appear free of substance. Usually 500 to 3000 ml of fluid must be instilled. After lavage, a second 25-gram dose of charcoal is instilled. Whole bowel irrigation. This procedure flushes the GI tract and theoretically decreases the GI transit time for pills and tablets. Irrigation has not been proved to reduce morbidity or mortality. Irrigation is indicated for any of the following cases: some serious poisoning due to sustained release preparations or substances that are not absorbed by charcoal, for example, heavy metal, drug packets, for example, latex coated packets of heroin or cocaine ingested by body packers, a suspected benzoate consumer, a commercially prepared solution of polyethylene glycol which is non-absorbable and electrolytes is given at a rate of 1 to 2 liter per hour for adults or at 25 to 40 ml per kg per hour for children until the rectal effluent is clear. This process may require many hours or even days. The solution is usually given via a gastric tube, although some motivated patients can drink these large volumes. Alkaline diuresis. Alkaline diuresis enhances elimination of weak acids, for example, salicylates, phenobarbital. A solution made by combining 1 liter of 5% demineralized water with 3 to 50 milli equivalent ampoules of sodium bicarbonate and 20 to 40 milli equivalent of potassium can be given at a rate of 250 ml per hour in adults and 2 to 3 ml per kg per hour in children. Urine pH is kept at more than 8 and potassium must be repeated. Hypernatremia, alkalemia and fluid overload may occur but are usually not serious. However, alkaline diuresis is contraindicated in patients with renal insufficiency. Dialysis. Dialysis is adopted commonly in case of the toxins that may require dialysis. These are ethylene glycol, lithium, methanol, salicylates and theophylline. These therapies are less useful if the poison is a large or charged polar